Welcome to the Scientific Dose. Today, we're jumping right into a really fascinating clinical review of how we assess kidney health and, diagnose some pretty complex renal pathologies. We're going to break down exactly how these vital organs function, how we actually measure that function with pinpoint accuracy, and what it looks like when things go wrong. Okay, let's set the scene. Imagine we're on clinical rounds in the hospital right now. A 60-year-old patient rolls into the ED with sudden oliguria, so a drastic sudden drop in urine output, and their lab work shows an acutely elevated serum creatinine. Now, I want you to think about this as we move forward. What is actually happening inside their kidneys at the microscopic level? Like, what specific biochemical pathways have failed to cause this sudden spike in metabolic waste? Keep that clinical scenario in the back of your mind. To answer that, here's our diagnostic roadmap for today. We'll start with the vital kidney functions, then look at the glomerular filtration rate, followed by creatinine clearance analysis. After that, we'll compare acute versus chronic injury, and finish up with that clinical patient case study.
All right, Section 1, the vital kidney functions. So, looking at a cross-section of the human kidney, it's like a highly organized filtration plant. You can distinctly see three major regions just working in total harmony. Out on the edge, you've got the lighter-colored renal cortex. This is the heavy lifting zone. It's where all the blood is initially filtered. Then, moving deeper, we hit the inner renal medulla. See those darker, fan-shaped structures? Those are the renal pyramids, and that's where the actual concentration and formation of urine happens. Finally, all that brand new urine funnels right into the center, the renal pelvis, which acts like a massive drain, directing the fluid down the ureter so we can excrete it.
Zooming into the microscopic level, we hit the nephron, literally the functional unit of the whole operation. There are 4 essential steps here. First up is filtration. Blood hits the glomerular capillaries, and fluid just gets pushed right into Bowman's capsule. Step 2 is reabsorption. As this filtrate travels down the tubule, the body basically says, wait, I need that, and aggressively reabsorbs water and essential nutrients back into the peritubular capillaries. Step 3, secretion. At the exact same time, extra waste products are actively dumped from the blood directly into the tubule. And step 4 is the finale, excretion. The final product leaving the body as urine is simply what was filtered minus what was reabsorbed plus what was secreted. That's the magic formula.
Moving on to Section 2, glomerular filtration rate. Now we're talking about glomerular filtration rate, or GFR. By definition, GFR is just the volume of blood plasma completely filtered by the glomeruli every single minute. Scientifically speaking, the absolute gold standard for measuring this is inulin clearance. Why inulin? Well, this plant polysaccharide is kind of the perfect marker. It's freely filtered at the glomerulus, and the tubules completely ignore it, so it's absolutely not reabsorbed, and it's not secreted either. What goes in is exactly what comes out. But there is a massive catch. To actually use inulin, you'd have to hook the patient up to a continuous IV infusion. As you can imagine, that is highly impractical for a busy hospital. So inulin strictly remains a research tool.
Which brings us to Section 3, creatinine clearance analysis.
Since inulin is out for daily use, what do we actually do? We use creatinine clearance, or CCR. This is the volume of plasma completely cleared of creatinine per minute. Now, creatinine is a total game changer because it's our best endogenous marker. Endogenous just means we make it ourselves. It's naturally produced as a constant byproduct of our everyday muscle metabolism. Because it's already floating around in our blood, it's the perfect clinical standard for estimating GFR. Now, full disclosure, there's a minor limitation. Unlike inulin, the renal tubules do actively secrete about 10 to 15% of our creatinine. Because of that extra secretion, creatinine clearance will always mildly overestimate the true GFR. But honestly, it's consistent enough to be incredibly reliable for clinical decisions. So how do we actually determine this for a patient? It's a precise 3-step process. Step 1, we have the patient collect a strict 24-hour urine sample. We really need to see their total daily output. Step 2, we measure the creatinine concentration in that urine, and we also measure their plasma creatinine concentration from a routine blood draw. Step 3, we crunch the numbers using the formula CCR equals U times V divided by P. Basically, U is the urine concentration, V is the urine flow rate over time, and P is the plasma concentration. When you combine those variables, the math literally reveals exactly how efficiently those kidneys are clearing out the plasma.
Next up, Section 4, acute versus chronic injury.
All right, using the tools we just talked about, let's contrast the two major pathways of renal failure: acute kidney injury, AKI, and chronic kidney disease, CKD. The fundamental difference here all comes down to the timeline and the trigger. AKI is a sudden, rapid drop in kidney function. We're talking hours or days. It's usually triggered by something severe, like intense dehydration, a systemic shock causing your blood pressure to tank, or sudden drug toxicity. CKD, on the flip side, is a slow, gradual, progressive decline in GFR and functioning nephrons. This plays out over months or even years, where the kidneys just slowly lose their long-term capacity to filter blood.
Let's look at exactly how this biochemical failure shows up on a patient's lab report. Let's go through this data row by row. First up, serum creatinine. The normal range is tight, 0.6 to 1.2 milligrams per deciliter. In renal failure, this value increases, and clinically, it's absolutely crucial because it acts as the best single marker of a declining GFR. Next is BUN, or blood urea nitrogen. Normally, it sits between 7 and 20 milligrams per deciliter. This also goes up during failure, which signals a dangerous retention of nitrogen in the blood. Third, we have potassium. Normal is 3.5 to 5.0 milliequivalents per liter. In failure, potassium levels rise, and this is a huge red flag. Hyperkalemia carries an immediate risk of a fatal cardiac arrhythmia, especially if we're dealing with an acute kidney injury. Finally, eGFR. Normal is 90 milliliters per minute or higher. Uniquely, this number decreases in failure. It serves as our absolute clinical gold standard for staging chronic kidney disease.
And that brings us to Section 5, the clinical patient case study.
Okay, time to put all this together. Listen carefully to this presentation. We have a 55-year-old patient with a history of long-standing diabetes. They come in with sudden peripheral edema, so really noticeable swelling in their legs, and they report having foamy urine. We draw their labs. Their serum creatinine is 2.8 milligrams per deciliter. That is highly elevated. Their estimated GFR has plummeted to just 25 milliliters per minute, a really significant decrease. On top of that, a urine test reveals severe macroalbuminuria, meaning they're losing over 300 milligrams of albumin in their urine every single day. Synthesizing all these numbers, the spiked creatinine and the crashing eGFR clearly tell us we're looking at severe renal impairment. But why the edema and the foamy urine?
To answer that, we have to compare a healthy glomerulus to a damaged one. What we're witnessing in our diabetic patient is glomerular proteinuria. Normally, your glomerular basement membrane carries a negative charge. It acts like a bouncer, repelling negatively charged proteins like albumin, making sure they stay safely inside the bloodstream. But because of the long-stand damage from diabetic nephropathy, that crucial negative charge is gone. The barrier physically breaks down. Massive amounts of albumin just leak straight through into Bowman space and eventually out into the urine. That excessive protein physically causes the foamy appearance in the toilet bowl. And because that albumin is no longer in the blood to hold fluid inside the blood vessels, the fluid leaks out into the surrounding tissues. Boom, peripheral edema.
Now, if we took this patient's urine, spun it down in a centrifuge, and looked at it under a microscope, we'd see urinalysis sediments. See, in a damaged kidney, we don't just see chemical changes, we literally see physical debris. We might find various casts. These are cylindrical protein molds formed directly inside the renal tubules. Think granular casts or even red blood cell casts. We might see crystals or even whole epithelial and white blood cells. Spotting these sediments gives us direct, undeniable microscopic evidence of the structural damage that we just measured chemically with our clearance tests.
We've mapped the whole journey today, from a healthy, functioning nephron right down to cellular destruction. We've seen how precise markers like creatinine clearance tell us exactly how fast our kidney function might be slipping away. So I want to leave you with this final thought. Knowing how incredibly delicate the glomerular filtration barrier really is, and how easily it can be compromised by everyday things like hypertension or diabetes, what daily interventions can we make today to preserve our nephron reserve for tomorrow? Thank you for exploring the complex world of renal diagnostics with me, and keep questioning the science around you.